that brings together the private sector in healthcare in Mombasa. And this is brought to you courtesy of the Kenya Healthcare Federation, together with the private sector engagement program of USAID and the county of Mombasa. And this is the first of a series of engagements that we hope to enter into and continue engaging with the private sector of Mombasa. I'll just take 2 minutes to just introduce who the private sector engagement program is, and then I'll hand over to our guest speakers to talk to us a little bit more about the landscape of the private sector engagement in healthcare in Kenya. The private sector engagement program is a program supported by USAID that intends to improve the availability of products and services through the private sector in the healthcare space in Kenya. We work in 5 counties, or we call them the 5 priority counties. Mombasa being the first one, Nairobi, Nakuru, Kisumu, Uasin Gishu, and we have Homa Bay, which is also coming on board pretty soon. So we have started off our detailed engagement in setting up private sector engagement mechanisms in Kisumu County, and Mombasa is our second priority county. That being said, there's an overwhelming need for the private sector to actually step up in terms of the services, in terms of how it is actually seen, the visibility of the private sector. It is there, but it's time for us to actually make sure that we're putting in place mechanisms and systems so that the voice of the private sector can be heard at all levels. If you look at how the private sector is organized, at the national level, we have very strong, robust engagement systems and mechanisms led by organizations such as KHF, which is the premier organization representing the private sector in healthcare across the country. And we want to figure out how do we replicate that kind of success at the county level, so that the private sector player at the county level is able to engage with government. The analogy I like giving is that Dr. Tim Theuri or Dr. Gakombe, who is the chair of KHF, can pick up their phone and call the Minister of Health to discuss an issue that is affecting the private healthcare players. At the county level, who is able to do that, and how can we set up mechanisms to allow for what is able to happen at the national level to also happen at the county level? Having said that, I would like to come back now, and we jump right into the meat of this particular baraza. We're going to have some brief presentations from KHF, led by their able CEO, Dr. Tim Theuri, and on the landscape on how private healthcare can support healthcare in devolution. And then after that, we're going to have a series of question and answers that will be fielded by Dr. Theuri. Hopefully, Dr. Gakombe will have joined us as well. We expected to have the CEC of Health of Mombasa County joining us. We will be keeping out an eye. I don't know if Dr. Obura, you can confirm whether we have the CEC on board, and or Dr. Adam, who is slated to lead the partnership portfolio in Mombasa County. If they are on board, we will also be we'll also ask them to say a word or two, and potentially also field some questions to them. That being said, I would like now to hand over to Dr. Tim Theuri to take us through the presentation by KHF. Over to you, Dr. Theuri.
All right, thank you, Lyndon. Dr. Gakombe has confirmed he's joining in shortly. Martin kindly facilitates sending him a panelist link right away so that he's able to join us. In light of that...
Dr. Theuri?
Yes, can I be heard?
Yes, you can be heard.
Yeah,
I'm jumping protocol here a little bit because I've
yeah.
just gotten confirmation from Dr. Ahmed Adam that he's actually on the panel. So,
All right.
Dr. Adam, probably
Fantastic. I can see him. Yeah. So it's only
if you could
fair he
welcome
talks.
us to his
Yeah.
county, yeah, and then hand over to you. Protocol has to
Yeah.
be observed.
We are technically in his house.
Exactly.
Yeah.
So,
Yeah.
Dr. Adam, over to you, sir.
Thank you very much. Once and foremost, this is a very wonderful platform that has been there. And I believe this is a wonderful platform for the county to be part and parcel and to involve the county together with the public and the private partnership that is going on. And we look forward how we can be working together and see how this can be a success. And as Dr. Marani has mentioned, I am the partnership coordinator, so I would be more than happy to coordinate together with my team and our leadership, including our CEC and our directors, are very happy with this platform to be part and parcel. I would be happy if this platform and moving forward we would engage together so that when we'll be having presentations and moving in terms of how it will be moving, it will be easier. But once again, it's been ad hoc and up and about. So we'll see how the engagement is moving forward. But we are more than happy to join in with the Healthcare Federation and the Public-Private Partnership. And we are very excited as County Government of Mombasa, Department of Health. Thank you very much.
Thank you very much, Dr. Arif, for joining us and your blessings on this. And now over to you, Dr. Tim Theory, with your presentation.
All right. Thank you. Martin, I think I'd like to share my screen at some point. All right, let me attempt that. All right. Lyndon, just tell me if I can be seen and my screen is shared.
Your screen is shared.
All right. So I will just request that you alert me the moment you see Dr. Gakombe online, so that we are able to have him talk for the sake of observing good protocol and good order. Also, just stop me in case you're not able to hear me clearly so that I can correct that. I am doing this outdoors, so a bit of some background noise. Allow me to do that for the time being. Lyndon, I'm still clear, I hope, yeah?
Very clear.
Very clear.
All right, thank you. So the purpose of this is to, at the end, what success would look like for us as KHF, the program as a whole, is that we have affordable care delivered to Kenyans, but it should also be available. You can have instances where you have affordable care that is not available because of other extenuating factors, and our work here is to ensure that there's an enabled environment for that to happen. Kenya Healthcare Federation is part or through its work works with other partners such as USAID, and on this particular engagement, we are together with USAID as a donor, Population Services Kenya as a prime, and Halcyon Consulting as our other partner on this, just to try and figure out what Dr. Marani was mentioning on affordable healthcare, and then he's mentioned something about commodities, which I'll be speaking about later. I will dive deep into what KHF does. KHF is a health board for KEPSA, that's Kenya Private Sector Alliance. This is our 20th year in existence, and among our founding members is, of course, our chairman, who will join us at some point. That is not to mean he's been here for life. No, this is just his first term. There was a founding chairman before that, and Dr. Gakombe is a man of the season. The way we are organized is that we have a board that takes care of the governance and compliance issues at KHF. We have a secretariat, which I have the privilege of heading, and we have committees that help operate operationalize what we do. As you can see, that is what I think I've just talked about. And we were formed as a strategic public-private partnership vehicle that has evolved to be more than that, just as any good organization should. And this is now the space we find ourselves in. Over 250 business member organizations, over 192 corporates, employing north of 40,000 people across the entire value chain of health. Health has largely been provider-centric, and as you know, these are the people who are facing the customer. So it's understandable that when we say Kenya Healthcare Federation, it largely think about providers, about clinics, about hospitals, but we take care of the entire value chain, from suppliers to distributors, to local manufacturers, to companies such as Population Services Kenya, who are in the healthcare space. These are service delivery entities. So basically, anyone who is in health in the non-state side is under KHF. Among the people who are our members are the professional associations as well, Kenya Medical Association, Kenya Dental, the pharmacist, and such like organizations. Private hospital associations as well are part of who we take care of, up to and including the faith-based organizations such as CHAC, KCCB, and facilities also under SUPKEM are our members. All right, just let me know if the slides are moving. So we also have working committees under KHF. And if you visit our website, you'll see how these have been organized and structured. And we have chairmen for these committees. They're largely mirrored on the 6 WHO building blocks: healthcare, health regulation and quality standards, healthcare financing, which has been a hot topic the last 10 years, supply chain, digital health, public-private partnerships, and human resources for health. So this is largely how. Yes.
Dr. Theory, as requested,
yes.
we have Dr. Kanyenje Gakombe online. If you
All
could
right,
introduce
fantastic.
as a matter of protocol.
Yes. Yeah. So thank you for that, Lyndon. Karibu sana, Chairman. You've just caught me rightly introducing KHF. And with your permission, I will request that you say hi to the good people of Mombasa and cue me in once you are done with that. Karibu sana, Daktari.
Asante, Dr. Theory. Good evening, watu wa Mombasa. Sorry, I've been traveling and flights were delayed, so that's why I'm dialing in late. And I'm pleased to be here, and I hope we'll have a good conversation about involvement and engagement in matters private sector, because we all need to work together to improve the space within which we operate. So, Daktari, I suggest you carry on. I will be on hand to engage and participate, because I'm here more to learn than to do anything else.
Okay.
Yes.
All right. Thank you, Chairman. Karibuni, everyone. So I will just pick up from where I was, and that is just talking about the structure of KHF. So at the board level, we have Dr. Gakombe, just like I mentioned, leading a team of fantastic people who are drawn from various subsectors in health. And then we have the secretariat, where I have the privilege of being with a fantastic team there. And now we have the committees, which have a dotted reporting line to the board as well as to the secretariat, and they also tend to also carry out their independent lobbying work, advocacy work, and also thought leading in the sector. And this is how they are mirrored, just as you can see on my screener that I have shared. And what you do is, the moment you join in KHF as a member, we will request that you pick an area of interest largely around this 6 lines. And of late, we have another subsector committee that is for providers, largely dealing with NHIF. And we've been leading the countries at national level, rather, the engagement with NHI for providers. What this entails is frequent contact with the fund on a monthly basis, following up on the debt that is owed, because that is largely the bigger issue, and also on other areas, collaborating in how they're implementing some of their projects and operations. So what is the current landscape? Every day at KHF, we're asking ourselves, what do Kenyans want? And by Kenyans, I mean, what do our members want? And what is the interpretation of that? What does that mean? When we get a call and the conversation is, we have new taxes on dialysis equipment, we have a new law that is affecting how pharmacists are going to operate. The latest has been the 4 landmark laws that have come into life last year. And we were deeply involved in that and just ensuring that we are following on the process. After that, we'll analyze the situation of the problem that we've been given. And we will draw from the networks we have, from our expertise internally, just to find what the data is telling us, because without data, you're not making meaningful decisions. And then the implications of that, what does it mean for business as people in the private sector? We have largely, like I say, what has been known is a for-profit side. However, like you have seen, we have also a big not-for-profit side that we take care of. But what does that mean for business? Even for our colleagues on the public side, we often we usually ask them this question, because if you do not ask this question, then it means your operations are may not be sustainable in the long run. And with the new laws, we have seen CECs now are having this conversation now. It's come to the front of their operations. What does it mean for them in terms of sustainability? Can I have more people employed? Can I have an extra facility? Can I bring in more equipment because of the analysis that I have received? For example, when FIF Act was put in place, we applauded it. But also what we are learning is in the lower level facilities, because of human resource constraints, then full compliance may not be possible just because of the nature of how the Public Procurement and Asset Disposal Act was set up. It did not have the health sector in its mind, and that has really affected how FIF is being implemented. And very soon you will see CECs appearing before Senate trying to answer some audit questions around this. So that is generally the nature of our work. Recently, what we've observed in the sector is there's a lot of distress because of liquidity. Health business is a liquidity business, and the profits and return on investment, if I may call it that, is realized over a long time. So the way money behaves when it comes into the sector in terms of tenure and the cost of credit is very different from what manufacturers and maybe financial services people and agriculture may experience. So with that, most of our businesses are micro, small, and medium enterprise businesses in the region of maybe 75 to 80%. The big boys account for less than 25%. And out of that entire pool, what you find is a back of the math envelope shows that up to 62% of these businesses are owned by women and youth. So you can begin to see the picture that is the non-state actor side of health in the country. Some emerging trends, and apologies, this doesn't seem to be quite clear, but I'll talk about it. We are really hoping, or rather my vision, or what I think will be success, will be a national health delivery blueprint for the country. We now have a broad-based government that has been put in place. Can they come up with a blueprint for the country so that we don't have this cyclic 5-year periods where at every election we are holding back? We don't know what the new governor will say. We don't know what the new president will say. We are just not sure. So how do we kill this cyclic nature of business for health? There's a lot of focus on prevention. A lot of digitization is happening. Public-private partnerships, I think, are the way to go. We have unutilized capacities on both sides. That is the public side and in the private side. How do we work with a lot of synergy to bridge these gaps? When it comes to oncology care, public side has the patient pool. When it comes to the private side, there are resources that remain underutilized. The radiotherapy machines, the cyber knives that are there in the private sector. That capacity is largely underutilized. And then, of course, efficient governance is a hot topic as of now. For most businesses in health, governance is tend to be seen as a cost point, but in the long run, it becomes an efficiency point, because with good governance, you are able to have systems, you're able to have structures, and with structures, then you're able to shepherd your people towards a certain vision. We are currently undertaking a couple of projects, and one of them is what has also brought us here. I will mention the rest. We have a USAID-funded project called Uongozi wa Afya Thabiti that is primed by AMREF. This is a governance project, and I think one of the wins under this project has been we've been doing board inductions for some pilot counties, and I believe at some point we will get to the coastal counties. We have done, I think, Taita Taveta. There's work ongoing in Kilifi, and when given the structure of the program, we hope to come into Mombasa as well. On this particular one, it's a health system strengthening project, and you can always reach out to us, and my team is available for this. That is to Dr. Ahmed, because it's largely on the government side. And then we have the PSC program, that's a private sector engagement program that we have talked about, and Linda and Marani, you may flesh it out a little later in the Q&A part. And then we have Women in Leadership, in Health Leadership program by Bill and Melinda, and we are working with the Strathmore Business School. The initial report on this is also out, so I will request Linda to pass it on so that you can see what it says. The broad strokes of it are that 72% of the healthcare workforce at the point of entry is made up of women, but when it comes to leadership, only 15% are able to break this ceiling. And then we have Africa Medical Equipment Fund with the World Bank and IFC Group. And this is to ensure that the lower level hospitals have access to financing. And this is being currently run through Cooperative Bank as a local partner. And I think there's conversation to expand it to include other banks that healthcare workers and facilities have access to. The changes in the healthcare sector, and these are what we've seen. We've seen a lot of legislative updates, technological advancements, and strategic shifts in UHC. And the legislative updates, the truth is that they have been aimed at policy stability. They have been they've come out quite strong, in my personal opinion, and this is possibly aimed at the changes that the Kenya Kwanza government promised to deliver on. So how do we align ourselves to these changes that are happening? And currently, the SHIF Act of 2023, a court case was instituted and a judgment was given. And I think I have seen we have received a note to continue giving our input in this regard. So when this kind of information comes to us, and then we come back to you in return, requesting that you give us information, kindly do so, because what this does is it helps us at the national level have our finger on the pulse at county level and even at the wider country level on what is happening. And this input is what is eventually given to the ministry, to the assembly, and at times even at presidential roundtables. Our chairman, Dr. Gakombe, sits at the board level of Kenya Private Sector Alliance. That's the largest private sector entity in the country as of now. And you can begin to see the picture of where health, if we had an issue, can quickly be channeled through even to the attention of His Excellency, our President. The strategic shifts in UHC, what does that mean for us? One of the particular areas that we have chosen to concentrate on as a program is on commodity security. Like I mentioned earlier, without commodity security, you will have healthcare that is affordable but unavailable. Commodities contribute a huge portion, up to that 8%, of what is used by the patients at the point of financial discharge. So if this component is coming in at an effective at a cost ineffective point, then the picture begins to be painted on how on the implication of business for the practitioners in general. I will not talk about or give a deep dive into the legislative changes that are happening, but this is the broad strokes of it. We are also getting interpretation of e-teams and all that means, given that the 2023-2024 finance bill also again suffered the same fate as the SHIF Act. So this is among the work that we get to do at KHF. In this cycle, especially the Primary Healthcare Act, PCNs, we now have private sector representation, and that was through the lobbying of KHF. And we now have an interesting problem of how do we now operationalize this, given that this was to ride on the SHIF or the Social Health Act of 2023. But I mean, that is our work. We are working hard at it to see how we are able to engage at that level. I think among the most important things, and this has been a big lesson and possibly a challenge to us, is that even as counties running its business, at the county health management team, is it possible for us to engage as private sector with them? Can we have a liaison person who's coordinating with the private sector from the county side, and possibly have quarterly meetings with the private sector so that we're able to tease out the issues, amalgamate them, and they also discussed at that level, be it regulatory issues, be it things to do with inspections, be it ease of doing business, the licenses that counties will want to levy. What we say is for business to happen, of course, licenses for sure have to be paid for, but what we encourage is an easy way of doing it. And a fair way of doing it and a responsible way of doing it, so that at the end of the day, it's a win-win situation for everyone. If the licenses are easy to levy, the fee is easy to collect, and of course, on-source revenue goes up. And just like we are told, if the city prospers, we prosper with it. So that has been largely been our outlook of it, and I hope we are able to bring these conversations home as we continue. Tech advancements. I think an online baraza begins to be the first point of how far this can get. And largely, we consider ourselves location agnostic, given the benefits of technology. And these are largely the changes, as you can see on my screen, that are happening. Strategic shifts in healthcare. This is what the landscape is looking like. This year alone, the conversations on integrating private sector in HIV care, in malaria care, in TB care have come out very strongly, and we have attended meetings where this has been the sole agenda. So we are moving from donor aid to what from aid to trade. That is the moniker that is being used, and this is towards in-country sufficiency. It's towards independence of Kenya in taking care of her own healthcare needs. Will this be easy? The answer is no. Is it doable? The answer is yes, but it can only happen if we walk the journey together. That is both public and private sector. One of the most fantastic examples our chair likes going back to his education sector. When the Minister for Education says that schools will close today, they will close today. When he says or she says that they will open tomorrow, they open tomorrow. And that is because there's a lot of harmonization in that sector. Is there good regulation? Maybe the jury's still out on that. But healthcare is better regulated for sure than the education sector. But can we have this harmonization happen in the way that does in the education side? And if you even look at the education side, there's a lot of semi-autonomy that happens. A school can buy its own bus. A school can employ its own teachers. A school can carry out its own project without a lot of reference to counties maybe. Can we have this model maybe work for hospitals? I don't know. But what can we borrow from it? I think the biggest thing that you can borrow from it, first of all, is governance. There's a lot of good governance in the education sector, and that is something that we can really drive back home for us in the healthcare sector. And that is what projects like the Uongozi wa Afya Thabiti that we do with USAID is trying to bring home, and now for private sector engagement. Human resources for health is also something that has been hot. We've had, I think, I don't believe, about 2.5 months of, actually 52 days, supposedly 2 months. 2 months of the last 8, that's a quarter of the time we've had in this year. We've had doctors on strike. So what does that mean? And out of that, a presidential task force was commissioned, and Dr. Gakombe, our chair, sits on it and heads the one of the committees on tech and I think human resource in health. We have a health labor market analysis report that was done by the Ministry of Health. And I think the highlight for that is out of the 187,300 people employed directly in the sector, private sector enjoys a 7% growth in employment, whereas the public is doing about 4%. And this is particularly not a bad thing, but it just paints the landscape of, if you want to build scale, where can we easily run to fast, but in a very collaborative manner. The public side saw freezing of employment at a point because of physical constraints, and that can begin to explain that difference in the percentage of employment. The private side, out of COVID, of course, lessons were taken, and now we have the build-up in terms of employment that we have seen. I will quickly mention this. This is something we are doing under this particular segment on local manufacturing. And the aim is to encourage production of pharma and medical equipment locally. Buy Kenya, build Kenya. I'm a big proponent of that because we have fantastic and amazing talent within the country. We want to reduce our dependency on imported health products. We can never do away with, of course, importation, but how do we play around with those ratios? As of now, our local farmer Kenyans are only doing between 1.8 and 2.1% of local manufacturing in the entire country. That's a little number, barely moves the needle. But if we are able, all of us, to move this to a double-digit number, you can begin to see the amount of money we can put into the economy, both through direct employment and indirect employment. And of course, support for local industry through good policy, incentives, and funding. All right, I will end there. The rest, in the interest of time, so that we're able to have a very robust discussion, I will request I leave it there, and possibly cue in Dr. Gakombe to possibly give a broader sense of things I may have left out, and have Marani come in thereafter. Thank you, everyone. Thank you for listening to me. Karibu sana, Chairman.
Thank you, Tim. How much more time do we have?
Lyndon, please advise. You are our
Yes,
the director of the show.
This entire meeting is supposed to take 1 hour, so we have about 20 minutes to go. And therefore, Bwana Chair will give you 5 minutes, so you can give adequate time for question and answer. I'm sorry for being a little bit truncated on time, but we have to close at about say 6 o'clock. So go ahead, Bwana Chair.
That's fine, Marani, and those I think will be enough for me. I have little to add to what Dr. Theuri has said, and what I'll say is basically for emphasis. The first thing I want to say is that devolution is not just KHF moving to Piat County. We've been on a journey of devolution since 1992, when we repealed Section 2A and allowed the sharing of power with a very powerful center. That sharing of power, whether it is liberalization of exchange rates, or allowing multiple parties, or allowing unions, because I was a member of the illegal union before the legal one came to be, or allowing trade associations and federations to exist and be part of the national decision-making as we chart Kenyans' way forward. There is space at the table for us. And I simply want to take us to what happened recently about the Social Health Insurance Act. You know, the courts said the act was unconstitutional. And one of the main reasons for saying so was that there wasn't adequate public consultation. I just received a reminder from the Senate saying, we wish to have your input. So there is space at the table, and we occupy that space among other occupants. But in order for us to truly leverage the opportunity, we need to have more of us on board in terms of numbers, and we need to have more of us on board in terms of positions, opinions, ideas, contributions, because team has access and we have access to various places, but we need to take to those tables and those places informed positions that are helpful to us as an industry. And that means that we must have a way of connecting every single player within the healthcare value chain all the way to the top. So let us use this opportunity and subsequent ones to really ensure that we are occupying that space properly. If we don't, then other voices will be heard, and laws that are made, rules that are made, regulations that are made will seem to be designed to favor certain people. But it's because those were at the table and made their position much more clearer, much more loudly than we did. And in this sector that we are in, for a long time, faith-based tended to find a more receptive ear than the private for-profit. But the key reason was because they had started off earlier. And of course, private for-profit was another novelty in the space. So I urge all of us to participate in utilizing the capabilities that, the opportunity that we've been given. Then on the current trends, there are many reforms going on. I've said many times, this is probably the greatest number of reforms being taken at the same time within the sector. Whether you are talking about SHA or digital health or the pharma manufacturing, there are quite a number of moving pieces. And it is important that, again, our bit is added to those moving pieces. And among the key trends that we see, one is a change from fee for service to fixed fee for service in the way that we are paid. The other is a change to insurance. SHA is about more and more people being enrolled in insurance, meaning there will be less cash, or people paying cash to us, and more payments coming through organizations that by dint of what they do will be powerful, whether it's private insurance or public insurance, being SHA. It is important that the rest of us also congregate and accumulate our power so that if push does come to shove, then we are able to push in the interest of a better health and delivery environment for the country. Then there is a tendency to consolidation, where organizations are forming chains, working together more, either formally or informally. I needn't go into HRH. I think all of us are familiar with the many strikes we've had in the public sector and people moving abroad. There's quite a bit happening in the human resource for health space. The latest is the Presidential Task Force, on which I'm privileged to serve. And we still have legal issues to resolve. But the point is, there is an effort that we address the human resource for health challenges that the country has been experiencing. Long story short, there is an opportunity. And power is never given. You negotiate for your share. Whether you're dealing with the Kenya Revenue Authority, with the challenges we are having in e-teams, or you're dealing with SHA in contracting and coming up with tariffs and contracts, it is absolutely fundamental that we have unity of direction and unity of purpose. And my hope and my dream is that as we devolve, devolution means that we will have longer reach, greater relevance, and the capacity to push even harder from all the corners of this country. So, Marani, I submit and hand back the mic to you. Thank you.
Thank you very much, Dr. Gakombe, for your words of wisdom. And just picking up from where you said that there is need for us to be organized all the way from the sub-county level all the way to the national level, for us to be better organized so that we can be able to take our place at the table and make sure that our voice is actually heard. And when our voice is not actually heard, we end up with some of the challenges that we are having. So now, ladies and gentlemen, we would like to open the floor for any questions that you might have. We are requesting that if you have questions, you put them in the question and answer box, which is at the bottom of your screen. And I would like to start off by asking a question to Dr. Adam on what is the county doing currently to engage with the private sector, and what is the immediate way forward in terms of your visualization of how the county is going to engage with the private sector. Dr. Adam.
Marani, I don't think is he on the call? Yeah, he's yeah.
He's on the call.
Yeah, okay, fair enough.
Yes, thank you very much. Unfortunately, my unmute mute button ends up messing up because I'm not the host, so I couldn't speak. But thank you for letting me speak now. Yeah, so as county government of Mombasa, we have set up different referral processes. Especially, we have the county referral coordinator as well, who has been in part and parcel, and we always get involved in public-private partnerships and the public hospitals and private hospitals, because as you can see, the highest number of facilities in Mombasa County is the private hospitals. So we need to engage with them and work together with them. And we have been engaging with them a lot when it comes to maternal and neonatal child health care, in terms of vaccinations, in terms of neonatal mortalities, in terms of maternal mortalities. So we have been bringing them aboard to look into how this collaboration can work together. As you can see that when the referral process comes in about from a private hospital being referred to a public hospital, and there's a mishap in between, there's a lot of disengagement that can happen, and it can lead to loss of lives. So we really value that the public and the private need to collaborate together to have that referral pathway being very smooth, in terms of if there's engagement that is required, if a private hospital needs to transfer a patient to a public hospital, or the other way around, where a public because of unavailability of resources or unavailability of staff or one reason or the other, it needs to be referred to a private hospital, then that referral pathway needs to be smooth. And I'm happy this has been brought in about, and we are happy to see how this, once the digitalization can be done, and we can be able to map out how these the facilities that are available can easily be able to share data or share information that is actually required, then action can be taken place. Thank you.
Thank you very much, Dr. Adam. Dr. Theory, there's a question that is in the question and answer box from Peter Nyaga. He asks, the issues of cash flows that you actually mentioned is actually at crisis level right now. NHIF is not paying, insurance is demanding compliance with e-teams, payments are at an absolute standstill. How does this get resolved, Dr. Theory?
I think we find ourselves in a very tough yet also unfortunate place. Like I mentioned, health is a liquidity business. If you're in the business of health, you're in a liquidity business. And even when you look at the public side, where most of the money is consumed is at community level, that is at the primary healthcare level. As you begin to go up, the spend per patient is what increases. Do you have that many number of patients up? Not as many as down at the community level, but that is a picture of which you begin to see. I think the crisis is at an all-time high in terms of payouts by the fund. There is also a lot of business uncertainty because of the way the transition has been going about. Not much of certainty has been coming in because of the transition that is currently happening. So because of that, you'll find there's a lot of holdback from businesses, from the fund itself as well, and a little also from our countrymen when it comes to seeking healthcare. Is NHIF active? Is it not? Is it still active? That's what the situation looks like. And what we are doing about it is continuous engagement with NHIF structure. What is coming out is there's a lot of money that is still owed by government and government agencies. I think to the tune of about 26 and 30 billion. If these monies were to be remitted to the fund, I think we would see a big jump and boost in what is happening. So that is the current situation. Principally, SHA is a better, the way it's been structured, it is better, but it will only be made better by improved efficiency in operations. That is the only way it becomes better. And if we are able to weed out corruption, and this cuts both ways, that is on the provider side as well as on the other side, because corruption does not happen as a one-sided venture. It is two sides of the stick. And unfortunately, we have had participants from both the public and the private side when it comes to that. We are encouraging reward of good practice as one of the solutions to this, so that if you have a facility in Mombasa and the data says that you're doing a good job, you should actually be rewarded by faster payments and to do as 100% as possible so that you continue to do the good job. And our colleagues who may engage in an ethical practice, then we begin to weed those out, because that is not right. If it is not right, it is not right. And that is what we are advocating for at KHF. And that is part of the engagements that we are doing. Also, a lot of conversations with e-teams, with KRA on e-teams as well. And Dr. Kakombe has been very instrumental on this particular bit. I can see Dr. Kakombe has raised his hand. I will also ask him to come in.
Thank you, team. The healthcare financing, which is one of the key pillars you presented, is a pillar we have to work on very hard. On one hand, we must get more money into the sector because the money simply isn't enough. Two, we must design economically sustainable packages, because part of the challenge that NHIF has had is that on top of the national scheme, they took on the let me call it the voluntary scheme, the one of 500 shillings per month, which has been loss-making, which has been subject to adverse selection, and which has partly contributed to NHIF not having enough funds. And they also took on various other funds, counties, managed schemes. They basically took on a lot without proper risk analysis, and in many instances based on a political number. And one of the risks that was never taken into account at that point, which has only now become apparent, is that whereas on paper, it looked like a great thing for the public service to insure with a public insurer, the reality of the matter is that when the premiums do not come, as is the case we're dealing with now, NHIF did not have the clout to stop services. So providers continue to render services. NHIF did not get the premiums. So basically, the missing premiums are counterbalanced by money that is owed to providers. So what are we doing? Some of the issues Dr. Theuri has alluded to. One is to make sure that the tariffs that will come up are economic. Two, and there is work starting or that has started on the contracting. Because unlike many private schemes that you've dealt with, you cannot shut down one part of NHIF and say, I won't do dialysis or I won't do the national scheme because it's not paying. I'll remain with the rest of NHIF. So one of the key things that we missed in the beginning was ensuring that there was a negotiated contract. So essentially, the private sector was a taker of both tariffs and contracts. So we are trying to make sure that the tariffs are better negotiated and there is good progress there. And also the contract will be a better negotiated contract that allows providers to stop providing service without being punished or victimized for failing to give credit they cannot afford anymore. So there is a future and there is a current. The current is to try and push so that the money which is held up comes into SHA, and that money is then paid out to providers in a fair and equitable manner. And the push includes pushing for the money that has held up from 2017. And one positive thing about the changes that are happening, and I'm very pleased to hear what is going on in Mombasa about, coordinating things together, because there are no private patients. There are only Kenyans accessing public or private facilities, and people move from one to the other. And it's a recognition we need to have to focus on what I call patient-centered care. One of the good things with the current reforms is that the counties themselves will be very aligned to the private sector way of thinking. That is the essence of all these reforms, because any governor, any CEC for health in a county will be collecting money also from the same SHA and using it to procure materials and get workers and provide service. So there'll be greater cooperation between providers, because providers will all be in the same boat. So it's dark now. We believe that as the money to SHA increases, we are likely to recover the historical figures and get more money coming into the sector. Thank you.
Thank you, Chairman. And
Go ahead.
possibly just to paint the picture some more, there is a bit that Chairman has talked about on the similarities between what the private sector is going through, and what is mirrored on the public side and even at county level. If you look at the way both are operating, the county side is cushioned through exchequer release in terms of liquidity, and we can begin. Of late, this has been quite infrequent as well, and we've seen our governors complain on this. But beyond that, the rest of the base is quite similar. So what chairman is saying is, how can we work together, both on both sides, to ensure that the common agenda of health and affordability and delivering it at a cost-efficient point still continues to happen. And I think with the FIF Act and, of course, other fiscal policies, the aim of having a little money for yourself is so that it can do other things that are not just pointed at service delivery, but the other supportive services around healthcare delivery. So this is what surplus will do in government. On the private side, then it will take care of shareholders, of owners of these businesses, and where we are faith-based businesses, then it goes ahead further to take care of the wider followership of the respective religions. Yes, thank you. Lyndon, over to you.
Thank you very, very much to our very able panelists, Dr. Gakombe, Dr. Tim Theuri. Dr. Gakombe hinted at something about the importance of the coordination of the private sector at all levels. I would like now to ask one of our important colleagues here, Dr. Elizabeth Gitao, if she could speak a little bit to what we're thinking of doing, what is being planned around the coordination of the private sector at county level. Dr. Elizabeth, what are your thoughts? Dr. Gitao, can you hear us? Okay, maybe I could actually throw it back to you, Tim, because you're also part of this team. Again, throw it back to you. So what are your thoughts about the organization of the private sector at county level? And then we will, if there are no other questions, we will then stop at that point and move forward to what we want to do next.
All right. I will answer it a little different. And this is from the training that I have seen go around. When you get such a question, set yours and then answer it. But the perspective I want to introduce is not a top-down approach to this, but a very organic buying in into an idea. And the idea here is seamless delivery of services across the value chain. Like I said, providers are the front-facing side of this spear, and it is very important that we keep them sharp so that whatever challenges this spear is facing, it is able to go through it. So my thoughts, my idea is that it should be very collaborative in terms of how it is carried out. And we should have that deep integration because we are all speaking towards the same thing. Therefore, the private side should have continuous engagements with the county government. And this can only happen if we are all willing to come to the same table, remove our quotes, public, private, put them aside out of the door, and just have honest conversations on how we can make this better. The context will vary from county to county for sure. So I do not expect this to be the same in what will be replicated maybe in Meru, Tharaka Nithi, or in Isiolo. Our context is very different. So let us make something or an engagement that works for Mombasa County and its peculiarities, if I may to say that. So it must work for Mombasa County first for it to make sense to continue with it. When it comes to things like sustainability and how do we move forward, it is, like I said, we are driving this from an ideology point of view, so that the people who carry it is not Dr. Gakombe and Dr. Theuri at national level. No, it is our colleagues at the county level who will carry this idea. What possibly at national level we would really hope to see is transmission of data when we call for it, opinions when we ask for them, when memoranda come and things like those, so that the conversation can be carried faster to the top. But most importantly, KHF, we have various engagements. We have members forums, we have CEOs forums. When we call for these meetings, come and join and let us share ideas and learn from each other. Lyndon, that is what I would think would be success for this engagement. Thank you.
Thank you very, very, very much, Dr. Theuri. I'd like to again thank all the speakers here today for giving us a clear idea of what KHF is doing, as well as what is the landscape of healthcare and its interaction with the private sector. I'd like to thank all participants for joining us today. These engagements with the private sector of Mombasa County will continue, and we'll be deepening these engagements with some of the participants in this particular phone call, probably joining us later on in the course of the week for a more detailed meeting at Bliss Hotel on Thursday this week. Letters of invitations have already gone out, and we look forward to meeting you there. Without further ado, we started off at 8 minutes past 5. And the meeting was supposed to last for 1 hour. So I abrogate the rule to actually call this meeting to an end. Probably, Tim, you had something to say?
Yes, I do have something to say. Martin is on the call. That is Martin Chege from KHF. My official title is Chief Executive Officer of KHF. My work is I'm the Chief Customer Relations Officer. That is my work. So I will request that Martin, should any of you, and I'm inviting all of you to join KHF, Martin will give an email through which this can be done. Martin, just kindly on the chat box, leave the office number as well as an email address that anyone on this call would wish to join KHF can do so. We will reach out to you through the email that is there. So kindly come into the house. It's a big home. And the good thing is it's a big home that is enough for everyone. It's a big home that takes care of all its children. And we really hope that we can begin to see this conversation go broader than just KHF at national level, but now KHF work going on in Mombasa as well. Later in the week, kindly come and join in the meeting that Dr. Marani has mentioned. I will be keeping abreast. I'll be kept abreast on what will happen. I think I will join in on one of the sessions as well, and keep Dr. Gakombe posted on what the outcome shall be at this particular level. My sincere and deep appreciation to Dr. Ahmed Adam from the county government of Mombasa for dialing in on the call. We run a fairly flat organization that is quite reachable. So let us know any collaborative points you may wish to have with us. Thank you, Dr. Marani. Over back to you so that we finish on time.
Thank you very much, Dr. Theuri. I suspect there's no more. I'm looking at the chat box. There is no more questions there. Please, as Dr. Theuri has said, the email address for KHF has been posted, as well as the telephone number that you could use to reach out to KHF. With that, ladies and gentlemen, I'd like to thank you all very much for attending this session. And for those who are going to be meeting on Thursday, see you on Thursday at Bliss.
Asanteni sana, mbarikiwe na muwe na jioni njema.
Thank you. Bye.